At the Global Liver Institute, we believe it all starts with a patient. So what happens when a patient, a liver patient no less, one of the 500 million people living with conditions that often go undiagnosed, untreated, or misdiagnosed, mistreated, and stigmatized, brings the challenges of liver patients front and center? And what happens when a patient then leads a discussion with world experts in policy, research, clinical care, and wellness on ways to overcome these challenges? Let's find out today on GLI Live.
Hello and welcome to this very special episode in March 2022. We're realizing that we're now going into the 2 years of having GLI Live, and as Donna Cryer, I am happy to be your host for this show and privileged to have these conversations. This is the start of our series of episodes featuring fantastic women in healthcare whom I look up to. I get that question often, who do I look up to? And so this is my opportunity to share them with you. And today we have Dr. Lisa Simpson from AcademyHealth. Welcome, Lisa.
Oh, thank you, Donna. It's a wonderful pleasure to be here. Always a pleasure to talk with you.
Thank you. Thank you so much. We have so much to unpack in just 30 minutes, and we certainly want to approach both how you lead as a brilliant, talented female leader in healthcare, but also the very unique role that AcademyHealth plays in healthcare. And so maybe start with your history and how you got involved in healthcare to start with.
Sure, absolutely. So I have a somewhat unique or different background in that I grew up overseas as the daughter of a diplomat. And so, and I went into medicine because as a woman, my parents really drummed it into me, the importance of education and financial security. And I love traveling. So I wanted a career that allowed me to have financial security and options. As a woman, my mother was always like, you've got to have options, never rely on a man for your income. So I picked medicine, and through a series of choices and opportunities, went from medicine to pediatrics, to public health, to health policy and health services research, and that winding path landed me with the very good fortune to become the CEO of AcademyHealth 11 years ago. And AcademyHealth is the national professional organization for health services research and health policy. And I know we'll get into that a little bit more, and I'll tell you what those words mean. I know you know what they are, but maybe some in the audience don't. But it's for many years, other researchers, because I am a pediatrician researcher at heart, really called my career untraditional. And I just like to call it unlinear, it's not traditional anymore.
Right. I think it's one of the things that makes you so impactful, and certainly speaking as a patient, you have a lens into connecting all the pieces of healthcare that often are not put together in a way that serve patients. And so I think that winding path, that untraditional career, serves you well and positions you really to be able to see and to design the future of healthcare, or at least the future as we'd like to have it to be.
Yeah, and I would also add two things, Donna, to your point. It's, I think, as not only my experience, but also as a woman experiencing all of those things, and as myself, a woman patient, because I am a breast cancer survivor, as you know, 21 years last December. And so I've both experienced the healthcare system as a woman who most women make most of the healthcare decisions for their families, even if they're not pediatricians like me, and I have children. So we make the healthcare decisions, and so we navigate the healthcare system. And then as a patient with a potentially life-threatening condition, having to go through that very directly and experience it from that position of extreme vulnerability and need. And I think all of that contributes to, as you say, sort of how I approach my work today.
You're correct that every woman is called the chief medical officer of their home, but you are actually a physician. So you are very qualified, more qualified than most to do that. But you're also more qualified to know how healthcare should be or could be, and then judge how you are experiencing it as a patient, and seeing where those gaps are, and knowing, like, if I weren't a doctor, I wouldn't necessarily know to do this, and filling in those gaps. So how has that influenced how you have led Academy Health?
So I think my answer to this question is different today than I think it would have been even 2 years ago. Before the events of the last 2 years, both the events of all the ramifications of the pandemic on our daily lives and its impact on our community and our country and the globe, but also what I am really experiencing for the first time, because I wasn't in this country in the 60s during the civil rights movement, is our country's really trying to grapple again with racism. And as Daniel Dawes calls it, a professor at Morehouse, the fourth great awakening. And so the last 2 years has I think further developed, how I lead, and how I lean into some areas that are really difficult for our field and for, individuals who are trying to lead at this time. So I think a couple of ways that I think my experiences, my lived experience, have shaped me as a leader is, first of all, I've always been a bit of an other in rooms. Now, many women physicians experience this. I was fortunate that, I trained in Ireland, where actually about 50% of my medical school class were other women, so not so much there. But, I remember the number of times where I'd go into a patient's room and the patient, man or woman, would say, "I love, the doctor's already been in here." The male medical student, I was the doctor. So, that sort of assumption of, what you bring into the room and your identity shapes how people react to you. And that I think certainly means maybe over the years I've worn high heels because I'm short too. So, we adapt to the context. The other thing that I think I bring to my particular leadership is understanding, in leading an organization, a small organization, we're a small nonprofit, 50 staff, is the importance of balancing life and work, or family and work, or whatever framing of that way that you integrate and understand that we spend a lot of hours at work. And the last 2 years have just reminded us of just how valuable and important our staff are to us. Talent management is so critical right now with the great reshuffling. So I think that awareness of balancing the two, I think, is really important. The other aspect of my background, and I don't know how much of this is due to the way I grew up traveling, but is the deep desire to understand multiple perspectives, because these problems we face in healthcare are not simple. They are deeply ingrained, they are systemic, and they have been built up over years, and they affect different people different ways. And so to solve challenges in healthcare, we have to understand it from those multiple perspectives. So I've always, health services research, my field, is multidisciplinary. Our members are from every walk of life, including, we've been working really hard to get more patients involved directly. We have a whole patient-focused program for scholarships and engagement. So I think those are some of the ways.
I am reminded in this conversation about the impact of your origins outside the United States, have on the conversations that we are now having on health equity. A lot of the GLI staff is either still is located outside the country, in the UK, in Italy, or has come from other countries. And I think it does help us who are born in the United States and make certain assumptions about the narratives, the conversations, the understanding of the roots of health equity. It helps us recognize that we need to explain it, put it into historical context, and that we are now speaking to a global audience, and that, how equity or disparities or social determinants of health are discussed in the United States with our unique, historical background, is different when we think about translating that to global health equity. So I think that your perspective and making sure that you're questioning this to make sure that we are translating it is one reason why I think we'll get it right, and why I'm so excited to chair a project with Academy Health on high value and equitable care. But it is
to
unique.
have you for sharing that. It's great.
Thank you. And as someone who has I've known Daniel Dawes since he was here in DC. It has been fantastic to see his work increasingly recognized. He was so prescient in the legislation that he was helping to draft to shine a spotlight and address these issues. And it's great that now he's getting attention and support. So you have this unique opportunity with Academy Health because of the diversity of your membership to really affect a lot of change, certainly in patient centricity and health equity. Tell us more about the Academy Health agenda.
Absolutely. So this year, we're going to be launching the campaign, or the party, so to speak, soon. It's our 40th year as an organization.
Wow.
We were established in 1982 under a different name. We've had a few names over the years, but we've been Academy Health for over 20 years. And so, as I mentioned earlier, we are the national organization for health services research and health policy. And if your audience is not familiar with the term health services research, what that is, one of the things I often use at cocktail parties to explain it to folks not in our world, is that while biomedical clinical research focuses on diseases of the individual, of the body, and how to treat them or prevent them, health services research focuses on the diseases, so to speak, of the system.
Right.
How do we organize, finance, and pay and deliver healthcare? And how do those choices at the system level affect the outcomes we achieve? So whether that outcome is various patient functional outcomes, patient experience of care, quality of care, the safety of care, or the cost of care, all of those are features of the system. And so health services research is really that research that began in the 1960s. It was before that, but really spurred by the establishment of Medicare and Medicaid to really help decision makers understand the pros and cons of different choices. And then once they made a policy choice, what was that impact, and was it what was predicted? And if not, how do you change that policy? So that's and it's used. Our research is used not just by public policymakers. One of the things when I started out sort of in this field in the 90s, this particular part of my career, I would, one of my jobs in the past was I was maternal child health director for the state of Hawaii. Every state health department has a maternal child health director. And then when I got into other more broader health policy, I would say that, as good a job as I could do as the MCH director for Hawaii, it was still only one half, women and children of maybe a total state population of 1.2 million at the time. Whereas United Healthcare, Anthem, Humana, these large health systems, HCA, they are serving multiple millions. And so those decisions that these private sector actors make also benefit and need health services research. So it's really about creating that evidence base for physicians, clinicians, health system leaders, the C-suite, as well as policymakers at the federal and state level.
That is very helpful. And yes, I'm sure many in my audience did not know what health services research is, but are really excited that somebody is doing that. How have you been working with patient communities? I'll admit I know a little bit about the answer to this question, but for our audience, how can patients help? How can patient advocacy organizations, contribute to the work that you do?
Terrific. So when I started at Academy Health in 2011, some of our staff had already launched the Consumer Patient Researcher Roundtable. So this was before the establishment of, or just as PCORI was, starting to be thought about and starting to ramp up. PCORI being the Patient-Centered Outcomes Research Institute that the Affordable Care Act established. And so we were already recognizing, because of our staff leadership, that having a better conversation between patients and researchers was absolutely essential to inform not just how the research is done, but which questions are asked, which questions are relevant to patients, and how they're approached. And then the role of engaging not just individual patients, but in the research process, but also the governance, the data choices that you make, the measures, and then the important final step, which is return of results. And how do you get your results back to patients? So our work started, quite a few years ago, over a decade ago. But now the last 5 years, we've really been pushing for that to be a much more systematic engagement with us. And so we have patient scholarships for all of our big events. Some of your audience may be most familiar with the Health Datapalooza, and that's in fact where we started with patient scholarships. We were able this year, the meeting is in a month, a little promo, April 4th. I can
we'll put the link in the show notes. Absolutely.
Great. And we have already 40 patients accepted scholarships, either virtual or in person. And we do that now for our other big events, our annual research meeting and our conference with the NIH on the implementation research that we need to actually implement good evidence-based practices. So that's one aspect. But part of that means that patients are involved in the planning. Patients are speakers. Patients are remunerated. They're paid for their participation. So that's really critical. We are also designing a patient member category. We haven't launched that yet, but we've been going through the process of governance with our membership committee, our board, to establish that. And really trying to bring that patient voice into all that we do. In addition, Academy Health runs a number of projects, collaborative for health related impact, funded by PCORI, Patient-Centered Outcomes Research Institute, other federal agencies, and we often partner with patient advocacy groups, as you mentioned, the Patient Advocate Foundation. We're working with you, Donna, on various things. I'm a board member of the National Health Council. So again, that critical link between researchers and patients, we really try to tackle it in a number of different ways, but we're always looking for ways to do it better. So open to that feedback from patients. And in fact, we've one of the last things we implemented this year for our annual research meeting is a box that you check in the review of the abstracts, the scientific abstracts, about whether or not this includes patient representatives in the research or in the reporting, to prioritize that. At least that gets sort of special recognition.
Working with Academy Health is one of the influences in the creation of our Advanced Advocacy Academy, because I want to equip our patients with various digestive and liver diseases to be able to participate effectively in the types of opportunities that you are creating, to partner on designing research or disseminating research. And I know that the leap from having a condition or being in an infusion chair to being in a room with the leaders of medical programs or academic medical centers and health systems or large payer systems can be quite intimidating. And so how patients can have the confidence, start to understand some of the language that's used, so that they can not just sort of warm a seat, as I say, but really participate fully and contribute, in those new roles is something that I'm, really excited. And a lot of our patients who, thought that being involved in research was just the clinical research or clinical trials, and didn't know that these types of opportunities to really think through how care was put together, they're really most excited to participate in that type of research, that they and are uniquely qualified. They have a great understanding of the things that didn't work in the system as they navigated care in whatever patient journey they have. And so I think the opportunities created by Academy Health are really exciting, and I'm excited to let more of our patient community know about them.
Fantastic. Again, we're always working to build this up and make it more accessible, and to really hurt, because the patient community, like all other things in life, is not one thing. It is a lot of different patient communities. While they're shared, experiences, it's also very important for us to make sure that we're hearing from all kinds of different patient communities. So, for example, we recently had a project funded by PCORI, an engagement award, that's looking specifically at children with special healthcare needs, something I know about as a pediatrician with experts in the field. And we have two different patient groups, family voices, and I'm going to forget the name of the other patient group because it was new to me, and that was terrific, and she's amazing. And so bringing, again, because there's so many sub communities within the broad patient community, we really want to try to support as many as we can.
Right. We've just finished with Rare Liver Diseases Month, and we're able to partner with so many different pediatric organizations, since many of the rare liver diseases are, of course, of genetic origin, and are manifested in while women are still pregnant, or when they're infants, or very, very young people. And so most people don't know that children can even have liver disease, so that's a new concept for them. So being able to start that council and bring those communities together has been some very, very exciting work. And it must be hard enough to be either experiencing a disease as a child or a teenager, or caring for a child and a teenager, and then thinking about how do I add on contributing to research or advocacy. And so trying to make it very easy for people to plug into that, is something that we're intentional about. One other, type of, diversity that, we're thinking about, together is in the health equity space. But that could take a lot of different directions. So how is Academy Health approaching, health equity, and what, what are at least the questions that we're starting to ask in terms of defining the space and the different, categories or populations of people that could be contemplated by this research?
Absolutely. So the reality is that health services research, I'm very proud of our field, and not taking any credit for it, but over the years, they have studied health disparities quite extensively. Our understanding that we know that there are differences in access, that there are differences in outcomes and differences in experience, that comes from health services research. And so we've had a disparities interest group for, I guess it was founded in 2006. We have disparities or equity tracks at all of our big events. We now have more tracks. We have an equity track, a racism track, a social determinants of health track. I think that and at Academy Health, to your point about diversity, we have had a Center for Diversity, Inclusion, and Minority Engagement since 2015. It was established with an investment from our board, recognizing we need to do more to address what our field in health services research will look like as a field and as a workforce, just like the rest of biomedical research, with underrepresentation of African American, Latino, and Native American researchers. And so we established that in 2015, and we have a diversity scholars program. But the events of the last 2 years really drove it home that, if you think about America, there's an old saying in healthcare that every system is perfectly designed to achieve the results it gets. And so the fact that we don't have a diverse workforce, that we have the disparities that we have, is that we're not we are creating in research, we have a system that is not rewarding the type of equity research and individuals that we need to change it and actually overcome these challenges. And so in the last 2 years, we've really taken a step back to address the sort of the system of research. In other words, who's doing the work? How do we get more diverse? We have increased the number of diversity scholarships through partnerships this past year significantly. How are they doing their research? Which communities and representatives and patients are being included? What are their skills? You know, race has been a variable in studies for as long as I can remember. What are you measuring when you put race in a research design or in an analytic model? Are you measuring racism? Are you measuring a social determinant? Do you understand all these forces that contribute to yield higher rates of poor outcomes? So we're really stepping back to try to improve all of those with a pretty major commitment. And in fact, diversity, equity, and inclusion was established as a strategic priority for Academy Health in 2020. We've got a lot of work to do still, but I'm proud that, you know, we're making progress. And then the other aspect, which is more kind of opaque or invisible, is that we're collecting data differently. So now we know the demographics of everyone who submits, everyone who reviews, so we can monitor, do we have unintended biases in our processes that are preventing a more diverse set of research studies to be presented and accepted. So,
well, you know, that's actually though being threatened, as there are some you know, bills being put forward at the federal and state level to disallow the collection of that type of data. Are there you know, threats to you know, the type of research that you and your board you know, is committed to do, that, you know, when we think about our policy framework to support you know, that you need to be able to continue
absolutely
that work.
Our committee, our board committee on advocacy and public policy is very much on this. In the last 2 years, we have submitted several comments to NIH, to OMB, the National Institutes of Health, the Office of Management and Budget, the Office of Science and Technology Policy, the Congressional Caucus on Social Determinants of Health, about the importance of health services research, of the data we need for health services research, and the quality and accessibility of that data, and the granularity of that data. One of our board members is Dr. Professor Ninez Ponce at UCLA, who is an expert on a number of these data quality issues, particularly when it comes to undercounting and lack of specificity for Asian Pacific Islander populations. And so we, in fact, are just now adding, with our Committee on Advocacy and Public Policy, a subcommittee on data policy, because we care deeply about this. And we work with the Data Coalition as well and others, but it's very much one we're active on.
That's excellent. You know, you can't change what you don't measure. And so I think it's important for patients to understand, as there's, you know, increasing transparency about the type of data that we are contributing to the system, and patients are asking why. It's these types of efforts to improve, you know, healthcare system, you know, performance, that these pieces of data, which sometimes, you know, whether it's I've seen a social media campaign about you know, patients who don't want to contribute, you know, have their weight taken, or, you know, patients who don't, you know, want different you know, parts of the medical record, you know, withheld. And I think that you know, it's beholden upon patient advocacy organizations to help patients understand about how these pieces of data beyond an individual's care really are needed to be able to understand how the system is or is not serving all patients, and really can be used now with our greater participation and insights into you know, to improve care and service. And so everybody has a stake in health services research.
That's right. I'd love to think that. And it always makes me very excited to talk with folks like you, who, you know, really are at the cutting edge of patient engagement and patient voice and patient centricity, because you help us create that bridge of these conversations between communities that have been historically quite separate. And our work is always better the more patient engagement. And so I'm really grateful to you, Donna, and to your colleagues for the work that you do.
Thank you. Well, I am so grateful to you, certainly for coming here today, but your long and esteemed history, and that is now part of Women's History and Women's Health History Month. So, Dr. Lisa Simpson, thank you.
No.
Please be sure to like this video, subscribe, and share your thoughts and suggestions in the comments below. Join us weekly on Wednesdays at noon Eastern Time for more episodes of GLI Live. Check out our website, globalliver.org, and follow us on social media to learn more about the Global Liver Institute and stay up to date with the latest in liver health. Until next time, stay safe, stay well, and stay connected.